Hello. So, toxicology, basic management, ABCD, airway, breathing, circulation, um, D is decontamination, I guess. So, for decontamination, to reduce absorption of the poison, usually done within 2 hours, multiple dose activated charcoal. There are drugs that have enterohepatic circulation, so this would be useful in carbamazepine, dapsone, phenobarbital, quinine, theophylline, and salicylates. There are poisons that are not absorbable to charcoal, and activated charcoal would not help. So acids and alkalis, alcohols, and metals. Okay, so acids, alkalis, alcohols, metals. These will not benefit from activated charcoal. Take care that if there is a paralytic ileus, there is a risk of charcoal aspiration and pneumonitis. So you have to make sure that the patient does not have paralytic ileus. Gastric lavage is no longer recommended. There's risk of aspiration and esophageal perforation. It's considered in very specific circumstances. But yeah. So enhancement of elimination is basically to enhance the excretion of a poison. So for diuresis, we give dextrose or mannitol, and this is helpful in renally excreted toxins with a low molecular weight and low protein binding because they can easily be filtered. For acidic drugs, we can alkalinize the urine, and then for hemodialysis, so there are drugs that are dialyzable: blast, barbiturate, lithium, alcohols, salicylate, and theophylline. There are drugs that are non-dialyzable and that it would not be helpful in, which is basically the abbreviation drugs like TCAs, BZDs, beta blockers, so tricyclic antidepressants, benzodiazepines, beta blockers, and opioid, dextropropoxifen, coproximol, and then digoxin. These are non-dialyzable. So we have to just remember the dialyzable drugs: blast, barbiturate, lithium, alcohol, salicylate, and theophylline. And then we can give antidotes. So organophosphorus, the antidote is atropine; warfarin, vitamin K; atropine, pyridostigmine; paracetamol, and acetylcysteine; digitalis, digibind; beta blocker, glucagon; calcium channel blocker, calcium chloride; methemoglobinemia, methylene blue; phenothiazine or TCA, we give alkali; benzo, sodium bicarb, benzo, we give flumazenil; carbon monoxide and hydrogen sulfide and all of these, and cyanide, we give oxygen; botulism, antitoxin; snake and scorpion, antivenom; methanol and ethanol, we give alcohol, so fomepizole or ethanol; opioids, naloxone; lead, we give calcium, sodium, edita or demsa or BAL, mercury also. For iron, we give desferoxamine, and then nicotine, atropine. Okay. Let's look at the summary of the common overdoses and management. So for paracetamol, if it's less than 1 hour ago, ingested less than 1 hour ago, we give an activated charcoal. Otherwise, the what is it called? Antidote is an acetylcysteine, and then liver transplantation. Salicylate, presenting within 1 hour, activated charcoal. If the levels are more than 500, we alkalinize the urine with IV sodium bicarbonate. If it's more than 700, we do hemodialysis. For opioids, it's naloxone. For benzo, it's flumazenil. So first, it's supportive care and oxygen, but flumazenil is a benzodiazepine antagonist, but it has a risk of seizure, so it's not indicated. It's only used if there is a severe or iatrogenic overdose. Why? Because in the hospital, you know the dose you gave, and you can titrate the flumazenil dose. Otherwise, it's very unpredictable and it's not helpful. It can cause a seizure. So you just give, if the patient has a benzo poison overdose at home, you just give them supportive care and oxygen. You don't give flumazenil. If the patient has a benzodiazepine overdose in a hospital, you can reverse it because you know how much you gave them. Okay, now tricyclic antidepressant. You correct the acidosis with IV bicarb. And also remember that TCAs are non-dialyzable, so you cannot do dialysis. Lithium, you can do dialysis, actually. If it's mild to moderate toxicity, you just resuscitate. And if it's severe toxicity, you can do hemodialysis. Warfarin, vitamin K or prothrombin complex; heparin, protamine sulfate; theophylline. Okay, so theophylline is one of the drugs that binds to charcoal, and it's also a dialyzable drug. So if it's severe, you dialyze. If it's within 1 to 2 hours, you use activated charcoal. Otherwise, you just give IV benzodiazepine as a fluid, and if the patient has tachycardia, you can give beta blockers. For beta blockers, you give atropine if it's bradycardic. If it's a resistant case, you give glucagon. Glucagon promotes the formation of cyclic AMP, which exerts a beta stimulant action on the heart. For ethylene, glycol, and methanol, you give fomepizole as the first line, and then ethanol or hemodialysis in refractory cases. Keep in mind that alcohols, activated charcoal does not work with alcohols. For OPC insecticides, you give atropine. It doesn't matter because this has never been mentioned in MRCP anyway. Okay, so for digoxin, if it's an unstable patient, you do DC cardioversion. If it's a stable patient, if it's a high digoxin level, you give digibind. If the patient has an arrhythmia, a VTAC, you give phenytoin or lignocaine. And you monitor a potassium and CKD because hyperkalemia precipitates toxicity. Iron sulfate, you give desferoxamine as a chelating agent. Lead, you give dimercaprol and calcium edetate. Carbon monoxide, you give 100% oxygen. And then if it's severe hyperbaric oxygen, for cyanide poisoning, you give hydroxycobalamin. Hydroxycobalamin. And you can give a combination of amyl nitrite, sodium nitrite, and sodium thiosulfate. Now let's look at the toxidromes. So we have the anticholinergic and the sympathomimetic toxidrome. They have some similarities, such as CNS agitation and dilated pupils. The difference is that anticholinergic is very dry and sympathomimetic is very wet. So anticholinergic, the skin is dry and red, the GIT is hypoactive, there is no, the urine is retained, and then the eyes are also irreactive as well. So we have dilated irreactive pupils because there's muscle paralysis. So basically none of the muscles are working. So you don't have any bowel sounds, you don't have any urination. Everything is just stagnant and dry, okay? And then there's tachycardia. For sympathomimetic, there's tachycardia as well, and there's a dilated pupil as well. But the difference is that the pupils are reactive in sympathomimetics, and then there's going to be normal bowel sounds, but then there's going to be hyperthermia, hypertension, flight of ideas, pressured speech, rhabdomyolysis, tremors, okay? And then the sympathomimetics are cocaine, amphetamines, theophylline, ephedrine, and caffeine. Anticholinergics are atropine, antihistaminics, antipsychotics, antidepressants, anything that has an antimuscarinic action. Antiparkinsonians and carbamazepine. Okay, now for the cholinergic, which is the opposite of the anticholinergic, so everything is wet. So salivation, lacrimation, urination, diarrhea, gastrointestinal distress, and emesis. The cholinergic drugs are the organophosphates, the carbamates, the physostigmine and neostigmine, and mushroom. For opioids, it's CPR3H, so coma, pinpoint pupils, respiratory depression, and then 3H, hypotension, hypothermia, and hyporeflexia. For sedative hypnotics like barbiturates, benzodiazepines, ethanol, propofol, chloral hydrate, there's CNS depression as well, like opioids. There's slurred speech and ataxia. And then it becomes coma, respiratory depression, hypotension, and hypothermia. So this is a quick comparison between all the toxidromes. So urine retention. The urine retention is only in the anticholinergic. That's the only one that has everything dry, right? And then the skin is also only dry in anticholinergic. And then the pupils are dilated in both sympathomimetic and anticholinergic, and it's pinpointed in cholinergic and opioids. Tachycardia, the sympathomimetic and anticholinergic have tachycardia. Opioids and sedative have bradycardia and hypotension and hypothermia. Okay. Now, for corrosive ingestion, which is basically the accidental exposure to household products. So according to the type of substance, it could be oxidizing, it could be an alkali. If it's an alkali, it will cause liquefactive necrosis and lead to esophageal injury. If it's an acid, it will cause coagulative necrosis and it will lead to gastric injury. So there's a lot of complications that can happen. Let's look at the management. So you look at the symptoms. If there's any drooling, vomiting, dysphagia, adynophagia, chest pain, you do an urgent upper GI endoscopy to assess the degree of ulceration according to Zargar classification. So you have different grades for the injury pattern in the esophagus. If there's extensive injury on the endoscopy, you do surgical exploration. Or if there are any signs of perforation, it's like surgical emphysema, mediastinal widening on chest x-ray, you also do an urgent surgical referral. High-dose IV proton pump inhibitors can be started if endoscopy is likely to be delayed. And then you avoid any oral intervention. So you avoid giving them anything in the mouth. You don't neutralize because that will cause an exothermic reaction and will worsen the injury. You don't induce vomiting or gastric lavage. For toxic gases, we're going to compare between carbon monoxide and cyanide. They are the most common hazards to smoke inhalation victims and fires. And the question may hint at badly maintained housing, student housing, blah, blah, blah. Cyanide may also be used in insecticides and other things. Okay, so what is the pathophysiology of carbon monoxide poisoning? Carbon monoxide binds to hemoglobin with a high affinity and reduces the oxygen carrying capacity of the blood. And it causes low oxygen saturation of hemoglobin and left shift of the oxygen dissociation curve. For cyanide, it inhibits cytochrome C oxidase and basically causes the mitochondrial electron transfer chain to stop. Okay, let's look back at carbon monoxide poisoning. There will be headache. Headache is the most common symptom of carbon monoxide poisoning, by the way, because when there's hypoxia, there is reflex vasodilatation in the cerebral blood vessels, and this leads to headache. Nausea, vomiting, vertigo, confusion, and weakness. And then if this toxicity is severe, there will be pink skin and fever, arrhythmia, and then coma and death. For cyanide poisoning, again, as we said, this inhibits cytochrome C oxidase and causes cessation of the mitochondrial electron transport chain. It will cause brick red skin and the smell of bitter almonds. If it's an acute poisoning, the patient will have hypoxia, hypotension, headache, and confusion. If it's chronic, the patient will have ataxia, peripheral neuropathy, and dermatitis. What do you do if this patient comes to you? First of all, you do a VBG or ABG. Keep in mind that the pulse oximetry may be falsely high. So you need to do a 4-wavelength spectrophotometry. And then you look at the carboxyhemoglobin levels. If the carboxyhemoglobin levels are less than 3%, this is a normal patient who doesn't smoke. Normal person who doesn't smoke. In smokers, it could reach up to 10%. But again, this does not mean that this is an acute poisoning. Now, from 10% to 30%, this is poisoning and the patient will have symptoms. If it's more than 30%, this is severe toxicity that needs to be urgently treated. What is a marker of severity? It's the cardiac ischemia. So you have to do an ECG, because if the patient has any sort of ischemia in their heart, this is a marker of severity. So what are the 3 things that we will do? ABG, carboxyhemoglobin levels, and ECG. Now, how do we manage? We give 100% oxygen, high flow oxygen, through a non-rebreather mask. It's administered as soon as possible for at least 6 hours or until symptoms have resolved. We have a target oxygen saturation of 100%, and this basically speeds up the elimination of carbon monoxide from hemoglobin and makes hemoglobin free so that oxygen can bind to it. Now, when do we give hyperbaric oxygen? We give hyperbaric oxygen if the carboxyhemoglobin is more than 25%, which is basically in severe toxicity, or if there are any neurological signs or loss of consciousness at any point. For cyanide poisoning, the definitive treatment is IV hydroxycobalamin, or the nitrite thiosulfate antidote kit. There are other indications of hyperbaric oxygen. Let's finish them. So, carboxyhemoglobin more than 25% or severe toxicity, loss of consciousness at any point, neurological signs other than headache, because headache is the most common sign and it's not a sign of severity. MI or arrhythmia, this is why we do the ECG. And then pregnancy, if the patient is pregnant, you immediately do a hyperbaric oxygen. And then if there is severe metabolic acidosis. There's another gas that could also lead to poisoning, which is called nitrous oxide. Nitrous oxide is an anesthetic agent. It leads to sensory neuropathy and myelopathy, so leg weakness and neuropathic signs. It is similar to vitamin B12 deficiency. Why? Because it interacts with vitamin B12. Prolonged exposure to nitrous oxide is usually needed. So it happens in dentists or like patients. Sorry, not patients. Patients. Dentists use nitrous oxide a lot for anesthesia for their patients. So they may inhale a lot of it and then get chronic toxicity. And they will experience neurological symptoms like muscle weakness, sensory abnormalities, etc. Now let's look at alcohol. So alcohol abuse, alcohol and drug abuse. Okay, so we have 4 types of alcohol. We have ethanol, isopropanol, methanol, and ethylene glycol. Ethanol is the one that is used in the beverages. It's also used in mouthwash and in cough and cold medications. Isopropanol is rubbing alcohol. It's used in mouthwash and solvents. Methanol is an alcohol that is used in paint thinner, photocopy fluid, windshield washing products. And then finally, ethylene glycol is the antifreeze that's used in cars. All of them can lead to intoxication. Ethanol will lead to CNS depression. Isopropranolol will lead to acetone and fruity breath. Methanol will lead to visual disturbance. And ethylene glycol will lead to renal failure. The treatment for all of them is basically fomepizole and dialysis. Methanol poisoning, you will usually see loss of vision. What is this? Okay. Loss of vision is seen in methanol rather than ethylene glycol. ماشي. So visual disturbance, loss of vision, methanol. حد شرب methanol, loss of vision. Methanol is metabolized by alcohol dehydrogenase to formaldehyde to formic acid. It leads to optic neuropathy. So we need to treat it urgently so that the patient doesn't become blind. We give the antidote, which is fomepizole. It's an alcohol dehydrogenase inhibitor. We can also give ethanol. Hemodialysis, I mean, we already established that methanol is not dialysable, so. And then we can give also folinic acid as a cofactor to reduce the eye complications. Now for the antifreeze toxicity, it will lead to metabolic acidosis with high anion gap and high osmolar gap. Metabolic acidosis with a high anion gap and high osmolar gap. And in stage 3, it will lead to kidney injury. A specific finding in ethylene glycol toxicity is low calcium. Why? Because the end product of ethylene glycol metabolism is oxalic acid or oxalate, which combines with calcium. Okay, and then the treatment is the same. So what are the special things in ethylene? The low calcium and the metabolic acidosis, high anion gap and high osmolar gap. Now for cocaine price has fallen sharply in the past decade, so it became a frequently clinical problem. Cocaine blocks the reuptake of monoamine neurotransmitters and increases dopamine, noradrenaline, and serotonin activity, and leads to generalized sympathetic action. Cocaine intoxication will lead to massive alpha and beta stimulation. So in the CNS, it will cause seizures, mydriasis, hypertonia, and hyperreflexia. In the cardiovascular system, it will cause a coronary artery spasm and hypertension. It will cause agitation, and then in the GIT, it will cause ischemic colitis. The classic case is basically a patient, a college student who's agitated, tremulous, tachycardiac, hypertensive with chest pain. Cocaine could also induce preterm labor in pregnant patients. And then if someone smokes cocaine, which is crack, they will have crack lung. So crack lung will lead to hemoptysis, dyspnea, and bronchospasm. Management. The first line management is benzodiazepine for most cocaine-related problems. Remember that it causes agitation and blah, blah, blah. So you give benzodiazepine. If we have benzodiazepine refractory status epilepticus, you do intubation and ventilation. For chest pain, you can give, you add nitrates. For hypertension, you add sodium nitroprusside. Don't use beta blockers because there's a risk of unopposed alpha-mediated coronary vasospasm. Okay. Now, opioid misuse. Signs of opioid misuse. We have already talked about the opioid toxidrome, CPR, 3H, CNS depression, pupil respiratory depression plus hypotension, hypothermia, and hypoxia. The complications are, sharing needles, injection. Okay. The opioid withdrawal will be the opposite of this. So hypothermia will be sweating. There will hypersalivation and diarrhea, vomiting, irritability, hallucinations instead of CNS depression. How to manage? We have harm reduction, which is the needle exchange scheme, and then we can also test for the viral viruses that are transmitted. In overdose, we give naloxone, which is a pure competitive opioid blocker with opioid antagonist with rapid action. Now, for dependence, the first line for detoxification in the UK, it's methadone. It should last up to 4 weeks if it's an inpatient and 12 weeks if it's in the community. And we usually do a urinalysis to check for compliance. Methadone is a full agonist of the mu opioid receptor with a long half-life. So naloxone is an opioid antagonist. It's used in acute toxicity. Methadone is an opioid agonist in the mu receptor, and it is used in withdrawal, okay, or dependence. Now, ecstasy or MDMA, methamphetamine toxicity. It leads to a sympathomimetic toxidrome and hyponatremia, or syndrome of inappropriate ADH, SIADH, okay? And how do you manage? You give dantrolene for the hyperthermia. Now, let's look at the rest of the drugs. So for salicylate overdose, it will lead to both alkalosis and acidosis. It's going to be a mixed respiratory alkalosis and metabolic acidosis. Why? Because the patient will have hyperventilation, centrally stimulates respiration, leading to respiratory alkalosis. That's early. And then late, due to the direct effect of the salicylates, it will lead to metabolic acidosis. And then it will be a mixed picture. Also, there will be fever and sweating. Why? Because salicylates cause uncoupling of oxidative phosphorylation, leading to decreased ATP production, more oxygen and carbon dioxide consumption, and more heat production. What are the other symptoms? Tinnitus, nystagmus, hyper and hypoglycemia, seizures, coma. Okay. How to manage? If the patient is presenting within the first hour, activated charcoal. If the level of salicylate is more than 50, you alkalinize the urine with IV sodium bicarb. If the level is more than 100, you do hemodialysis. If it's 100 milligrams per deciliter, or if it's more than 700 milligrams per liter, or if we have metabolic acidosis resistant to treatment, and then if we have something severe like acute renal failure, pulmonary edema, seizure, or coma. What is the non-steroidal most likely to cause convulsions? It is mefenamic acid. Interesting. Now let's look at paracetamol overdose. Normally, the paracetamol is conjugated in the liver with glucuronic acid or sulfate. If we have a lot of paracetamol, this pathway becomes saturated. So the paracetamol shifts to be oxidized by P450. So it's not normally oxidized by P450. It's normally conjugated. But if we have a lot, it will shift. And it will produce NAPQI. So the metabolism, the CYP450 metabolism, by the oxidases of paracetamol will lead to a toxic metabolite called NAPQ. Normally, glutathione conjugates with this toxin to form a non-toxic mercapturic acid that's excreted. When glutathione becomes saturated, the toxin will accumulate and will lead to hepatocytes and renal tubular toxicity. The main issue is liver toxicity. However, you have to also keep in mind that in significant overdose, there might be delayed nephrotoxicity as well. Now, let's look at the time frame of toxicity. Within the first 24 hours, the patient will have unspecific symptoms like diarrhea, nausea, malaise. After 24 to 48 hours, the patient will have abdominal pain, and the lab values will start to be abnormal. Within 3 to 4 days, there will be the peak of hepatic dysfunction, and then after 4 days until up to 14 days, there will either be recovery or there will be complete liver failure, depending on the stage of the patient. What is the risk factor for hepatic toxicity? If the patient is malnourished or if the patient was taking liver enzyme inducers. What is a protective factor for a paracetamol overdose? Enzyme inhibitors and acute alcohol. Is acute alcohol an enzyme inhibitor? I think so, yes. So chronic alcoholics will have higher risk of hepatotoxicity after paracetamol overdose. All patients are treated the same. So again, activated charcoal if it's less than 1 hour, and then NAC. It's infused over 1 hour. It may cause an anaphylactoid reaction, which is a non-IgE mediated mast cell release. You just stop the infusion and then you restart it at a slower rate. And then you can plot the serum concentration of paracetamol against the time since ingestion to predict the possible liver toxicity. This is called a Romac Matthew nomogram. If the timing of presentation is less than 8 hours and the level of paracetamol is on or above the treatment line, you treat. If the time of presentation is after 8 hours and the patient has ingested more than 150 milligram per kg paracetamol, you treat. If it's more than 24 hours and you have liver affection, you treat. If there's any doubt about time of ingestion or if there is a staggered dose, you treat. So these are the indications of N-acetylcysteine. Now, there are specific criteria for liver transplantation, which is the final treatment for paracetamol overdose. It's a rule of 3 for a paracetamol overdose. Rule of 3 for a paracetamol overdose. The rule of 3 is that if the pH is less than 7.3, if the PT is more than 100, if the creatinine is more than 300, or if there's grade 3 or more encephalopathy. Okay? And then if there's acidosis, so pH less than 7.3, PT INR more than 100, creatinine more than 300, mental change encephalopathy grade 3 or more. So these are the 4 indications. Sorry, these are not the 4 indications. It's either acidosis alone or all of the others, okay? So that's how to know whether or not a liver transplantation is indicated. What is the single most important prognostic factor? It's the arterial pH. And this alone is enough to decide that the patient will need to have liver transplantation. So again, if it's less than 2 hours, you give activated charcoal. If it's 2 to 8 hours, you measure the paracetamol concentration. If it's above the on or over the treatment line, you treat. If it's under, you don't treat. So how about if it's more than 8 hours or more than 24 hours, you start. And you measure the paracetamol concentration. If it's under and if it's low, you stop. If it's not, you continue. You continue acetylcysteine. For criteria on when to cease acetylcysteine, see above. Okay. Now, beta blocker overdose, the main features are bradycardia and hypotension. If it's bradycardiac, you give atropine. If it's resistant, you give IV glucagon. Hemodialysis is not effective for beta blockers. For tricyclic antidepressants, particularly amitriptyline and doxyulepin is dangerous in overdose. TCA has a large volume of distribution and a long half-life. It will lead to anticholinergic effects and then also sodium channel blockade effects, so arrhythmia, seizure, metabolic acidosis. So you're going to have sinus tachycardia and then widening of the QRS. If the QRS is more than 100, seizure. If it's more than 160, arrhythmia. How do you manage? You give IV bicarb to correct the acidosis. That's the first line. It's indicated when the QRS is either more than 100 or the patient has a ventricular arrhythmia. The second thing is antiarrhythmics. Avoid class 1A and 1C because they prolong depolarization, and also avoid class 3 because they prolong QT interval, and the TCA toxicity already increases QT interval. And then IV lipid emulsion is used to bind free drug and reduce toxicity. Remember, TCAs are non-dialysable. For serotonin syndrome, we already know what will happen. How do you manage it? You manage it with benzodiazepine. What about if the case is severe? If it's serotonin syndrome, you give cyproheptadine and chlorpromazine. If it's neuroleptic malignant, you give dantrolene. Now, lithium. How many are left? Okay, not much. Lithium toxicity. So lithium has a very narrow therapeutic range, 0.4 to 1, and a long plasma half-life, and it's excreted primarily by the kidney. Toxicity occurs after concentrations of more than 1.5. If it's more than 2.5, that's severe toxicity. What are the risk factors? Renal failure, dehydration, and drugs. Damn. Diuretics, especially thiazides. Thiazides cause sodium loss, and when there is sodium loss, there's increased lithium reabsorption and toxicity because lithium is handled like sodium. So when there is hyponatremia, there is lithium toxicity. And then also ACE inhibitors and ARBs, and then metronidazole and nonsteroidals. These drugs are risk factors for lithium toxicity. So diuretics, especially thiazide diuretics, and then ACE inhibitors and ARBs, and then metronidazole, and then non-steroidals. Now, if we have a patient who's chronically treated with lithium, they may have fine tremor. In toxicity, they will have coarse tremor, hyperreflexia, confusion, and then polyuria or diabetes insipidus. How would you treat? You just do volume resuscitation with normal saline to rehydrate the patient and promote renal drug excretion until the patient is euvolemic. And you monitor serum sodium, especially if there's a concern about lithium-induced nephrogenic diabetes insipidus. If the toxicity is severe, you can do hemodialysis, and then you can also alkalinize the urine with IV bicarb. So, again, this diagram shows the narrow therapeutic range. So from 0.6 to 0.8, that's the therapeutic range, and it will have fine tremor. You monitor lithium with serum lithium and UNEs and TFTs. If it's more than 1.5, that's when you start getting toxicity. And if it's more than 2.5, that's severe, in which you need to do hemodialysis. Okay. For digoxin toxicity may occur when the concentration is within the therapeutic range. It will have yellow-green vision and arrhythmias and gynecomastia. The precipitating factor for digoxin toxicity is hypokalemia. Why? Because digoxin normally binds to the ATP phase pump on the same side as potassium. So when there's hypokalemia, digoxin will bind easier and will increase its effect. This is unlike lithium, which was precipitated by hyponatremia. Also, hypomagnesemia, hypercalcemia, hypernatremia. So the opposite of lithium. And also the opposite of hypokalemia. Hypoalbuminemia, hypothermia, hypothyroid, increasing age, renal failure, and then a lot of drugs. A lot of drugs will compete with digoxin for secretion in the distal convoluted tubule. And also any drug that causes hypokalemia, like thiazides and loop diuretics, will also increase the toxicity of digoxin. How to manage? You correct the arrhythmia, you monitor potassium, and you give digibind. Okay, next is theophylline toxicity. Theophylline will cause GIT irritation, and then it will lead to catecholamine release, so there's sympathetic stimulation, so there will be tachycardia, arrhythmia, hypotension, and then it will also block adenosine receptors in high dose, and it will decrease the inhibitory effect of adenosine on the CNS, so it will lead to CNS stimulation, so agitation, seizures, rhabdomyolysis, hyperthermia, hyperventilation. And then there's metabolic effects, so it will lead to hypokalemia, hypomagnesemia, hypophosphatemia, and then hyperglycemia and hypercalcemia. Okay. How to manage? You give multiple dose activated charcoal within 1 to 2 hours. You give fluids. You give benzodiazepines for seizures. You give esmolol for tachycardia. And then if it's severe, if there's a seizure, if there's an arrhythmia, if there's hypotension, you give hemodialysis. Quinine toxicity is basically something that causes tinnitus and confusion and blurred vision, and it's a drug that's not commonly used, and it will cause prolongation of QRS and QD intervals, and it will cause hypoglycemia. You just need to correct these things. There's a differential diagnosis of quinine with aspirin toxicity. However, the difference is that tinnitus, deafness, and visual defects, which may occur with aspirin, are usually transient, whereas in quinine they leave permanent neural damage. So you just need to do a serum salicylate to exclude aspirin, and then you just do supportive treatment with fluids, inotropes, and bicarb. For metals, iron sulfate is common in children because it resembles sweets, and it's a physically corrosive metal, and it also leads to mitochondrial toxicity. So different stages. It will lead to GI irritation, and then there will be recovery, and then it will lead to a high anion gap metabolic acidosis, dehydration, and lactic acidosis, and then it will lead to hepatic toxicity or hepatic failure. And at the end, it may lead to scarring and bowel obstruction. You just give it a spheroxamine infusion. Now for lead basically inhibits ferrochelatase, which converts protoporphyrin to heme and leads to the formation of hemoglobin. So when you inhibit that, you're going to have I guess, anemia. So a microcytic anemia. There will be abdominal pain, constipation, motor neuropathy, and blue lines on gum margins. Something else that is caused by lead poisoning is anterior uveitis, which I recently read. Substance levels, blood level more than 10 microgram per deciliter is diagnostic. If it's more than 5 for children and pregnant women, it's diagnostic. Now, the serum and urine delta aminolevulinic acid will be high, and this will be difficult to differentiate from acute intermittent porphyria. So you would need to measure the urine coproporphyrin, and it will be high. For the blood film, there will be basophilic stippling, and then X-ray long bone, which is not part of the standard workup, but there may be lead accumulating in the bone metaphysis. The management is by dimercaptosuccinic acid, DEMSA. And then the other options are D-penicillamine, Edita, and dimercaprol. If we have a question that's giving a combination of abdominal pain and neurological signs, it could be either porphyria or lead poisoning, so we have to look at the urine coproporphyrin. Now for mercury poisoning, mercury is going to lead to corrosive damage and visual field defect, hearing loss, paresthesia. It's seen in organic mercury, ingestion of the contaminated seafood. This is the neurologic one. Inorganic mercury will lead to the gastrointestinal one. That's it for toxo. I just want to look at AIP just to know what's elevated. So in AIP, is coproporphyrin elevated? There will be porphobilinogen in urine, not coproporphinogen. But the porphobilinogen and the delta aminolevulinic acid will be high. Now let's look at the poisoning section. I just want to see if there's anything that I haven't revised. There are different clues, so if there's a fast irregular pulse, it could be salbutamol, antimuscarinics. Well, if you understand the toxidromes, then you will be able to catch this easily. Okay. ABC. Clear the airway, consider ventilation, treat shock, assess the patient, do investigations, monitor, treat, give antidotes or specific measures. You should also always measure the point of care glucose, I guess. Okay, let's continue. Designer drugs with chemical properties similar to illegal drugs. Ooh, designer drugs. They are legal, but they can be deadly. These drugs are out there. Okay. Some specific poisons and their antidotes. We've already revised this. For anticoagulants, if it's a major bleed, you give vitamin K and prothrombin complex. If it's an abnormal INR with minimal bleeding, CBNF. Okay, thank you for nothing. And then just revising each poisoning. This is the normogram, I guess, for paracetamol poisoning. And yeah, that's it. What is snakes? For snakes, it could lead to anaphylaxis. You would just avoid actively moving the limb, avoiding incisions and tourniquets, and you can give IgG antivenom. Paraquat poisoning causes DNV, painful oral ulcers. It's diagnosed by urine test, and you can give active charcoal followed by laxative and avoid oxygen. Okay. Phenothiazine poisoning, dystonia, blah blah blah. You just give dantrolene. Okay. Bye.